I mean, I've heard about a dry cough. I've heard about muscle soreness and diarrhea, but have you heard about blue urine? Because that's an actual drug side effect I found out.
This is Tyler's research.
This is why I don't do the show. It's because it would all be this sort of thing. This is Generation Health. Every week we bring you the latest in news, cutting-edge research, and time-tested best practices, helping you live a longer, healthier life. Sitting to my right, PharmD, certified strength and conditioning specialist, goofball extraordinaire, Dante DiMatteo. How are you?
Not too bad, Tyler. Sorry about that little mishap earlier.
I don't know what you're talking about. Neither will anybody else, because we're going to edit it out.
No one will know.
Joey DiMatteo, PharmD, board-certified clinical nutritionist. How are you?
Very good. Thank you, Tyler.
And look, you didn't have to make weird noises that we have to edit out.
Not me. I would never do that.
Another person not making weird noises, Josiah Schweinberg, mic number 4. How are you, engineer?
You said that with a lot of faith.
I'm hoping. Please don't make weird noises.
I'm doing very well. Thank you, Tyler.
That was beautiful and articulate. And I am Tyler Andrews, your host. Dante, what are we talking about today? Or do you even know?
We are... Dude, wait.
We're going to do a follow-up to last week's episode with a few more side effects. We talked about side effects last week. We're going to get a few more just because it felt appropriate to really drive this home exactly what is to be expected in that world. But first, we're going to talk about what's happening behind the counter. The FDA has granted breakthrough device status to SetPoint Medical's novel neuroimmune modulation platform for people with relapsing remitting multiple sclerosis. This designation enables the company to receive priority regulatory review with the FDA, meaning the device could come to market much sooner. MS is an autoimmune disorder that involves damage to the myelin sheath, a protective layer around individual nerve fibers. The damage disrupts signals to and from the brain and can lead to a cascade of debilitating symptoms such as visual impairment, trouble walking, pain, and cognitive difficulty and fatigue. In short, it is completely debilitating. SetPoint's new device uses precise vagus nerve stimulation to activate the body's anti-inflammatory functions and lead to remyelinization of the damaged nerves. While there are pharmaceuticals on the market that can help slow down the disease progression and even ease some of its symptoms, there are no cures currently available and nothing that addresses the root cause, the damage to the myelin sheath. We hope this device proves effective and we can finally have a workable solution for the nearly 1 million people in the US who suffer from this horrible disease. And dog lovers rejoice. A small study in South Korea was just published in the journal PLOS ONE. Is that how you say that? PLOS ONE? I think that's how it's said. That attempted to document how specific activities with a dog can affect a person's brain. The study involved 30 adults around 28 years old outfitted with an EEG device. The EEG electrodes attach directly to the scalp and measure electrical activity in the brain. It's an instantaneous way to get a measurable insight into what parts of the brain are actually active at a given moment. Participants began seated in a bare room for 3 minutes to minimize any unrelated activity being measured. After that, the test subjects were led into a room with a well-trained dog to spend time doing several different specific activities with the dog, including feeding, grooming, playing, hugging, and walking the dog. Before leaving, participants filled out a questionnaire about their emotional state. While past studies have relied exclusively on the subjective self-disclosure questionnaires, the EEG readings gave researchers clear insights into how each specific activity affected the brain. Walking and playing with the dog increased the strength of alpha band oscillations in the brain. This generally indicates mental stability and relaxation. Grooming and massaging, on the other hand, increased beta band oscillations, which is associated with higher concentration and heightened attention. While the study wasn't designed to determine exactly what mechanisms were causing these reactions, it is great to be able to link specific activities with specific effects. No word on whether these results would apply to cats, but I certainly have my doubts. Okay, that's it, boys. I'm putting you on the spot. We talked a lot last week about ADRs, adverse drug reactions, ADEs, adverse drug events, side effects, what they are, how they happen, all that stuff. And I know that it was just the tip of the iceberg, that there's thousands more potentially that we can't possibly hope to get to. But for the purposes of being as thorough as possible, let's cover a few more. Specifically, I want you each to give me 5 ADRs that you commonly advise people about in the pharmacy, in your daily work, things that you see all the time or you commonly have to talk about. Ready? Okay, go.
All right. The first one I have is related to Chantix, which is a medication that helps people quit smoking. So essentially, it's a mimic of nicotine. So you're not giving your body the nicotine, you're trying to replace it with this medication, hopefully over time, that can help you not to need the smoke or the tobacco.
That's good.
So the side effect, and this occurred very early on when the drug came out, was they didn't use this term, but we know that Chantix causes vivid dreams, but when it was presented to me was I'm having nightmares. Chantix is giving me nightmares.
Wow.
So it's just an important distinction. It doesn't cause nightmares. It's not, altering your psyche in any way, which I mean is a reasonable concern.
Right.
It's not doing anything like that. It's just making the dreams that you're having more vivid, more lucid, and also able to be recalled more easily.
Wow.
So does Chantix directly affect sleep quality? Not in the most direct sense, but if you're having these dreams and you're having a hard time, recovering from waking up to this, whether it's a good dream or a bad dream, whatever the case may be, certainly then that has a big effect on your overall well-being. So at the time, I think what's different about this medication, Chantix, you're using it as an adjunct to help you to quit smoking or using chewing tobacco.
Right.
This is not like, hey, I'm, treating blood pressure and I can't alter this dose, or I'm using an anticoagulant and so I'm having this side effect. I'm going to start cutting my dose. This is, again, simply an adjunct to maybe some therapy and some other things that you're doing, some replacement exercise and just doing some other things.
Yeah.
So ultimately what I'm trying to say with that is that there is the way the medication is set up, it kind of comes in a package and you ramp up dosing. It's meant to mimic you coming off of cigarettes or tobacco in general. So what was helpful here was that, again, this being, like I preface it with, more of a fluid situation in terms of you stopping using tobacco, do the lower doses cause that? So with this person, we were able to get to the point where the lower dose, the 0.5 milligram dose, was not having that same effect. And was it helping as much with quitting smoking? No. But again, with the fluidity of this,
right,
it still was an adjunct. It still helped. It still, I remember saying, like, smoking half cigarettes, that kind of thing. It's just lowering your body's need for it, which then hopefully over time lessens the reward parameters, et cetera, that are all kind of intertwined with this. So the lower dose helped. And in this case, it was a pretty easy move to do and pretty easy thing to kind of interject in.
Okay. All right.
I think that is so fascinating.
What do you mean?
That it would cause deeper dreams, more be
vivid
able to recall
dreams.
it more. And I don't know if it has anything to do with the fact that, like, nicotine or those types of things, they affect your sleep, right? So then now you're sleeping more deeply.
Yeah, I mean, that's a good thing to go into. But I think overall it seems to be more specific to Chantix. Like this,
interesting.
This is not like oral nicotine. It is a nicotine receptor agonist. So it's a mimic of nicotine that's hitting those receptors. So in doing that, you've got some nuances and some differences.
Sure.
So it's not like, well, how come whenever I smoke a cigarette before I go to bed, I don't have these vivid dreams, but when I take Chantix, I do. One, the activity level's longer. That has a big thing to do with it. Part of this mimic and the difference is that it lasts longer in your body, which is what you want to help you resist those cravings. But it is a little more specific to this being still a unique agent.
I'd be interested just to remember my dreams.
We cannot recommend that you take Chantix.
More off-label use. Here we go.
Yeah, so I started looking it up a little bit, and some people were like, "Oh yeah, this is awesome! I had this incredible dream," and the next day,
Wow.
But then other people, I mean, obviously it's very psychological. I certainly don't pretend to know in depth about this, but with if you're just going through some hard times and you're having some things going on, and you're in this opposite situation where you're having these nightmares.
Yeah, you don't want
people
those
are waking up with
dreams.
and they're remembering these nightmares, and it's 3 a.m. and they can't fall back to sleep.
Oh my goodness!
It's pretty crazy. Yeah.
All right, Dante, give me one. What do you got?
I have a really fun and novel one.
Oh boy.
No, just kidding. Statin-associated myopathy.
Totally novel. Okay. Statin-associated myopathy. So statins are from cholesterol.
Yeah, so the lipid-lowering therapies, simvastatin, atorvastatin, that class of medication, most people know them. A lot of people are reluctant to start them because of this oft associated side effect in most instances ends up just being very mild muscle pain, muscle weakness, that sort of sensation. In other cases, it can progress to a much more serious extent, to the point of some muscle breakdown, to the point where you need medical attention. So it has occurred, but I must stress that is a rare occurrence. And as we sort of mentioned in the first episode, there are options that the individual has, that the clinician has, as far as, whether or not you need to switch the medication, lower the dose, change the dose, monitor certain things while taking the medication, certain baseline characteristics that you can look at before being started on a statin. But in general, one of the key takeaways is to, if you are somebody that was started on a statin and you do notice some muscle discomfort, some weakness, this is something you're better off just letting, your pharmacist or your doctor know right away, as opposed to letting it get worse. I mean, there's a good chance that it can self-limit after that short time of being started. But this is something that's worth getting out ahead of, because there's so many other options.
And that was one of the big takeaways from the last episode, was talk to your care providers about any adverse drug reactions you might be experiencing. So that makes sense.
Exactly. A lot of times, if you are in maybe what would be considered a higher risk population for these myopathies, these are individuals with impaired renal function, hypothyroidism, maybe a genetic or predisposition or a family history of myopathies in using these medications. That would be an instance where creatine kinase might be measured before starting. I honestly don't know how frequently this actually occurs.
Yeah,
I can't actually speak to that. But that would be something in a crude sense that would just measure muscle breakdown at a very baseline level.
Okay.
There is still the chance that if you are on a statin, you have these, myalgias or this myopathy that's occurring. The creatine kinase may not be reflective of that. It might remain normal and you still experience that sensation. There are instances where both of those things are elevated at the same time. So it's not a 100% surefire way to know.
Right.
But for those even more apprehensive, I suppose, or you're in this high risk category, I suppose it wouldn't be the worst thing to know.
Yeah.
But yeah, in general, there are certain statins that are more or less likely to be responsible for this. Simvastatin has been around for a long time. In higher doses, is one of the more likely candidates to be associated with this. So nowadays, you don't see simvastatin much higher than 20 and 40 milligrams, I would say, at the highest. So at this point, individuals being initiated on a lipid-lowering therapy like this, we see Crestor or rosuvastatin in lower doses requires less of a dose oftentimes to elicit some of the same effect of some of those higher doses of the older agents.
Ones, yeah.
And it seems to lead to less of that occurrence. So there's always the option to change the drug if you've been on one of the older ones. There's always the option to lower the dose if you've been intolerant to a higher dose. These myopathies are quickly reversed. Usually it's a month or two, I would say, at the top end, depending on the severity, or shorter. But something to, if you're not already aware, something to be aware of.
Sure. Excellent. Joey, give me another. What's something you talk about often behind the counter?
This is an exciting one. SSRIs, and more particularly Zoloft and Lexapro, and diarrhea.
Oh,
yeah, thought you'd like that one.
I didn't know that.
There are. So this occurs. up to 16% of patients. There was a meta-analysis of 84 trials found that. And again, you're dealing with outpatient settings here. How many of these are being reported? So it's very common. And I think what's critical here is that this is not like, I've been taking this drug for a week and I had diarrhea twice. This is persistent virtually all day long. It is pretty serious. And a lot of times when people are starting on this medication, they're in one of two camps. There's a whole lot going on in their life and they are diving in and they're dealing with this. And this is one of the ways that they're going to manage what's going on, anxiety or depression.
Right.
And then there's the other camp of like, I'm kind of nudged into it. I kind of know I probably need to deal with this, but I'm looking for any way out. I don't want to take this. I see I can't take it. So I think it's important to know, how it happens is that there's serotonin receptors in your gut as well as in your brain.
Right. Yep.
Certain people, a significant percentage are just a little more susceptible to the medication activating those and being active in the serotonin gut sites. So it increases the motility in the gut, which is what's going on leading to the diarrhea. So there is some, there's a lot of evidence that does show that over time, your body does kind of rebalance and re-regulate itself relative to the motility in the gut. So anywhere from a few days up to a few weeks, this will resolve. So, this is a tough one. This is persistent diarrhea for a few weeks.
Yeah, that stinks.
But again, it just really depends on, like we always talk about the risk reward and the balance and being open and honest. What is going on? What can you do to manage it? First and foremost is kind of the clean diet. I mean, you can go all the way hardcore to like the brat diet, but even just, grilled chicken, less inflammatory type foods.
Sure.
The basics there, potatoes, rice, grilled chicken, white bread, those kind of things, to at least help manage it. And there's honestly, especially in this phase, there's nothing wrong with some Imodium. Over-the-counter Imodium, deal with the symptom, get over this hump, see, if this drug's for you, but don't allow this to be a limiting factor. Because again, it does put a pause on a significant amount of people in those early weeks.
Yeah. Something that can help a lot of people. You don't want it to be shut down because of that. Makes sense.
And the other thing to be very careful with is the dose. A lot of times, especially for anxiety, Zoloft is used at higher doses. So that doesn't mean that they're going to crank you up right away, but often they're starting you maybe at a 50 instead of at a 25. So you're more susceptible to it. And you're more susceptible whenever doses are ramped. So you may have kind of regulated on the 50s, but maybe the 100, your body's just not going to kind of click back and you make a decision there. Is the 50 worth the balance and the risk reward of potentially something that's not quite resolving maybe at a higher dose. So as always, the recommendation with this one is not just to manage it, but just be open and, deal with it and process it with your doctor, even though it's not the most fun thing to chat about.
Sure. Yeah.
How long is too long? You said a couple days, maybe a couple weeks.
It can be up to a couple weeks.
My goodness.
Yeah. So, I mean, honestly, if you're pushing 2 to 3 weeks with this, it's time, if it's warranted, maybe that you're on a 50 or 100 to just back down. Or even though these medications, the core ones we think about, the Lexapro, Celexa, Zoloft, even though they're all in the same class, there are certainly nuances to the chemical themselves and also how your body responds to them. So while Zoloft may cause this pretty intensely in you, a simple switch to Lexapro simply may not cause it. So that I would say after about 2 to 3 weeks, it's time to do something.
Yeah.
And kind of go from there.
I'm asking for a friend.
All right, Dante, your turn. Give me another.
Oh man, so many to choose from here. I would have to go with, we'll talk antibiotics.
Sure.
Doxycycline specifically. This is one that, I think always comes up on the boards. To what extent that this is occurring in practice is hard to say at this point. But with that specific antibiotic, you have an increased photosensitivity or increased sensitivity to the sun while you're taking the medication.
Meaning it hurts your eyes or meaning your skin is more sensitive?
Yes,
okay.
Your skin is more sensitive to the sun. So pretty simple. I don't think it's worth going into the whole mechanism by which this occurs.
Sure.
But in general, this is something that when we're checking somebody out, we mention, especially if we notice this is a new, a new medication for them, an infrequently prescribe medication for them. As doxycycline can occasionally be used for more extended periods for, if somebody has had Lyme's or recurrent bacterial infections, skin infections, rosacea. But if this seems like a one-off for them, I think it's worth mentioning to maybe use a little higher SPF than normal, or if they can, just avoid that prolonged time in the sun.
That makes sense. I think I was prescribed that not too long ago, and I remember the doctor saying the same thing, except that it was like the middle of January, so there wasn't a lot of risk of being out in the sun too much.
I mean, it seemed like before there was, in younger individuals, it was I heard a pharmacist on rotation say no tanning for a certain amount of time. So it seems like tanning beds are not as popular anymore.
I was gonna say tanning beds seem to have declined in popularity, but some people are still into
a thing.
That.
Yeah.
Ugh. Joey, you got another?
So my next one is a pretty common one. It's ibuprofen and naproxen or NSAIDs, that class of meds with ulcers and stomach pain. The reason why this occurs so commonly is that these medications are anti-inflammatories. They inhibit the cyclooxygenase or COX enzymes. So there's COX-1 and COX-2. So COX-1's role is to produce prostaglandins in the gut. So that makes up your gut mucosa, the lining of your stomach. So when you inhibit COX-1, you're blocking that process from occurring.
Got it.
So I think what's key here, there are a couple levels to it, but patient presented with, hey, I've been taking ibuprofen. Okay, you've been taking it for 2 days. You take it a couple times a month, or you've been taking it. I'm on my feet all the time. My knee's been terrible. I need a, knee transplant soon. I take, 400, 600 milligrams 3 times a day. It's over the counter. I've just been popping it. So now you've been doing that for a few weeks. And now you're at much increased risk for stomach ulcers. Obviously, especially if you have a history of them, that increases risk. The other thing to always be careful of in terms of using these medications at all is if you're on any type of antiplatelet or anticoagulant. So again, theme is not an issue to take it once in a while. This is not, if I take ibuprofen, I had an ulcer 6 years ago, I'm having an ulcer. This is persistent use. Multiple weeks, often multiple times a day. And I think the other thing to, in this situation in particular, but in general, an alternative to naproxen or ibuprofen over the counter is Tylenol. Tylenol is not going to cause these issues. There are also some cardiovascular and kidney concerns with long-term ibuprofen and COX-1 inhibition via these NSAID mechanisms. So Tylenol outside, yes, there are liver concerns, but that's really only at mega Tylenol doses. That's with heavy alcohol consumption. That's with some, pretty uncommon medications that are very hard on the liver. You would know what those are. In general, Tylenol is a much safer alternative for you if one way or another you're going to be using some over-the-counter pain medication very often. It's a much better option.
Okay.
Yes.
All right. Dante, I like this back and forth. This is fun.
This is crazy. This is cutting edge.
This is it.
Cutting edge.
Every episode
we got the 808s.
from here on out, it's going to be AB, AB, AB.
And C.
I don't even know what just happened. Hey, remember when you said you were going to make goofy noises back there?
Keep them coming, Josiah.
Fired.
Sorry.
Dante, give me another common counseling moment that you have.
So it's not a medication discussion in 2024 without a mention of GLP-1 agonists.
Hey, there it is.
There it is.
So as we've really hammered home, they're everywhere.
Yep.
So with that, you should understand the not only the positives, but also what can occur, especially in the early stages of using the medication. Not to be scared from it, but it is worth understanding. So the most common side effects when starting are these GI side effects, of course, that we've mentioned. So nausea, diarrhea, and constipation potentially. So depending on which sort of end of the spectrum there that you fall on, there are some different things that I suppose you can try. But firstly, with nausea, hey, I don't know that there's a whole lot that you can can do at the outset with trying to prevent nausea. I mean, you can say try to stay hydrated, try to consume your normal amount of fluids on a daily basis. I don't think that overdoing it is going to prevent the nausea from occurring. There's not a real special plan of attack there, unfortunately.
The GI issue, these are an example of it kind of doing its job a little too well, at least initially, right?
Sure. Yeah. As we know that the delayed gastric emptying is a side effect on one hand, and also, part of why it works so well in that it slows the transit of, the normal transit of food throughout the GI tract. So in managing that, I don't know how evidence-based this is at this point, but we suggest, I've heard others suggest eating smaller meals to start to try to be better prepared for what can occur. I don't think it's a bad idea. I think that individuals notice a pretty stark reduction in their appetite shortly after using it. So I don't know if there's a huge risk with starting to eat smaller meals, especially as you try to mitigate some of the side effect risks. I think that is certainly a logical response. I know I mentioned fluid intake, but I also don't think that overdoing it with fluids makes a whole lot of sense too, because individuals quickly can find themselves on the constipation end of the spectrum, unfortunately. And so with that, it's trying to eat more and more and drink more and more doesn't bode well in that circumstance.
Yeah.
And also sort of, off the cuff recommendation, consider the foods or the restaurants or the patterns that you eat that are more or less likely to cause some GI upset for you. So if you love getting ice cream every other night, like I do, and there's a little bit of a trade-off with how you respond to it from a GI perspective.
Yep.
Maybe that's something that you put on pause as you're starting a medication like this that already has an inherent potential for some of those issues. In the same sense that I notice when I am eating more at restaurants versus what I'm cooking here at home, some of those these similar GI issues start to arise. So if you find yourself in that camp, maybe for the first 2, 3, 4 weeks, the majority of your meals are something that you have more control over. There's not a ton of oils in them. They're not overly, fatty dishes. And that's not to say that you stop enjoying yourself, but at the same time, again, we just see so much of this occur in those earlier stages. Controlling a handful of those variables can be helpful.
Yeah.
So smaller, more frequent meals that you know exactly what's going in them, avoiding some of the foods that are for you more likely to upset the apple cart, so to speak.
Yeah. The point is
that even a saying?
Upset the apple cart?
Oh, sweet.
Yeah. You did good.
Thanks.
No, the point is these are common side effects and we're trying to make people aware and help them know how to mitigate them so that they can get the help they need.
Yeah.
Does that make sense? Mm-hmm. All right, Joey, what else you got? You got another one for me?
So the next one here is a very common issue. It's certainly one that men do not like to discuss very often, but it's regarding sexual dysfunction. Mm-hmm. This involved a patient that was recently put on both an SSRI, so the Zolofts, et cetera, that we spoke about, Lexapro, the antidepressant, anti-anxiety meds, and a beta blocker, which is used for blood pressure, elevated heart rhythm, post-MI, those, all those different conditions. So I think what muddies this a little bit, and this is kind of more of a real life one in that sense, is like, he went from basically not taking many meds, not seeing his doctor much, to all of a sudden now he's kind of dealing with everything. And now he's on both of these medications. Now he's also dealing with issues at home and with the side effect. Again, really serious issue. And I think it was cool that there was comfort level with, discussing it with me. So I think that whenever two variables change and something occurs, and now you're going to try to change two variables again, that's a mistake.
Yeah.
So the way that, my approach was, obviously this will all be done in conjunction with his provider, is to attack the lower hanging fruit, which is the SSRI. Not surprisingly, he kind of says, I was reading about it. I looked it up and, so I kind of been skipping it. So right there, we're dealing with, some of the fallout of having side effects is basically he's skipping it. So, obviously discussed with him, that's not ideal because you're just not the medication's not going to work the way it's supposed to. This is not an acute use med. It's not a PRN as needed med. So to see if it's working for you, to make that judgment, which already when you're dealing with depression and anxiety is multifactorial and very difficult to quantify. It's not a situation where you can look at a value, at a number on a lab and see if it's moving. It's much more difficult anyway. So leave the beta blocker alone for now. If eventually that needs dealt with, deal with it. But essentially would recommend switching to a different antidepressant. Maybe initially you could look at dosing, but I think this is a newer medication. It's Chantix. It functions a little bit differently than the SSRIs. It still has that reuptake, basically allows your synapses to recycle and reuse the serotonin it's already produced. This one has also activity as a serotonin agonist. So it's increasing the feeling of serotonin in a little bit of a different way. It's acting like serotonin and as well as the reuptake inhibition. So they have direct studies comparing Chantix with Lexapro and Zoloft. Significant decrease in the rates of sexual side effects. So some, mitigating things here, potentially. Cost is a concern. It's a $400 a month drug. It is newer. A lot of patients have high deductibles, things like that now. Yeah. So again, there's often concerns down the road.
There's a trade-off.
You could make this switch and potentially it's working, or he really wants to try it and he's got a $3,000 deductible. It's out. You know what I mean? There can be so many levels. Obviously we see the pharmacy end, so I'm more aware of those, but that's definitely an area. So we definitely try to step in and get patient manufacturers where we can to help them out there. But to me, that was if you start trying to alter both the beta blocker and, the SSRI, you end up potentially lowering the therapy of both when maybe only one was needed and there's a good alternative. So,
juggling too many things at the same time is never a good idea.
Yes. That was pretty clear recommendation there. That is something that is very common. Like we talked about, in the previous side effects episode, in general, a lot of people don't talk about their side effects with their providers. And when you throw in something that can be, quite honestly, can be for a lot of men, embarrassing to discuss. Now you're adding to that factor. You're adding to the reticence to discuss it. So
absolutely,
just know there are things that can be done that don't necessarily involve you not being able to take those meds.
Makes sense. Dante, give me your best one that you haven't covered yet.
This one would be the dry cough associated with ACE inhibitors.
Okay.
So ACE inhibitors are another class of hypertensive medication. And again, this is a very common, pharmacy board question sort of side effect, but something that, I've heard on rotation occasionally will pop up amongst, colleagues and such, still counseling patients out in the real world. So yeah. The dry cough that's associated with these medications, the medications being something like lisinopril or captopril, any of the prils that end in that suffix are most commonly associated with this. Ultimately, what's most important is to understand what you can really do about this. There's another class of medications that work very similar to the ACE inhibitors. So if that's not something you have already tried, these are the angiotensin receptor blockers, which are like a, sibling drug to the ACE inhibitors. They work very similarly. There's less of a risk with this dry cough for the dry cough in that class. So oftentimes somebody switching from a lisinopril to a losartan, that class is commonly known by their suffix of the sartans or the sartans, losartan, valsartan.
Okay.
So in that case, switching to one of those agents, because one of these two are often used as first-line medication treatment for hypertension. Oftentimes you'll see people switch back and forth or have to jump between classes. And you might be wondering, what's the deal with a dry cough? Can't I just kind of
deal with it?
Can I sort of deal with it? It's something you do want to mention. There additional issues can arise there are issues with angioedema or sort of swelling of the, circulature that can lead to a whole cascade of issues. So it can be, not in all cases, can be a little more than just this, little bit of a tickle in your throat.
Okay. So it can get out of hand and people don't realize that.
Yeah. Or it's often associated with some other issues, some other side effects associated with the class. So.
Again, bottom line, if you're dealing with a side effect, if you're dealing with an adverse drug reaction, you need to talk to your providers.
Probably not worth fighting through for any reason.
Yeah.
At least worth mentioning.
That makes sense. I have to say, I am, it never stops impressing me how much you guys just know off the tops of your head and are able to share with people on the regular when you are working with people over the counter. It's really impressive.
Hey, thanks, Tyler.
Absolutely. Which means now I need to quiz you.
Naturally.
I mean, I've heard about a dry cough. I've heard about muscle soreness and diarrhea, but have you heard about blue urine? Because that's an actual drug side effect, I found out.
This is Tyler's research.
This is why I don't do the show. It's because it would all be this sort of thing.
Tyler, I'm very impressed by you right now with this blue urine.
It's because of Pyridium.
Aha.
Mm-hmm.
Is this like from Wakanda?
I don't know. That's all I know is that there's a drug called Pyridium that if you take it, it can result in you having blue urine.
This is bizarre.
So amitriptyline, triamterene, two pretty commonly used meds can cause it as well.
No kidding.
He just one-upped you, I
Yeah,
think.
he totally did.
Absolutely.
That was very impressive.
Off the top of my head, too.
Okay. All right. Well, what about missing fingerprints? If you're going to rob a bank, you might want to be on Zolota because your fingerprints will vanish. Maybe.
Yeah. In all seriousness, though, hand-foot syndrome is essentially what the root cause of that is. So Zolota is a chemotherapeutic agent. So you get redness, swelling, dry and cracked skin, peeling, cracking, and it occurs at the palms of the hands and soles of the feet.
Wow.
So it's more commonly occurring in palms than the soles. Okay. So it's not anything eerie or crazy to do with the fingerprints themselves. It's just an unfortunate, pretty severe side effect of what's going on with the skin in the area. Okay. And it does resolve, and it does typically occurs within 2 or 3 months of treatment and resolves within a couple weeks after.
You made that a lot less fun.
He one-upped you and then made you look really cold.
Yeah. I thought it was funny. Okay.
If you're going to rob a bank, and he's like, actually, no.
Because of what the medication
Don't
is,
do that.
all.
Don't do that. Okay. Loss of smell. We got anything funny for that? Anything not funny for that? Loss of smell is kind of funny. Vasotec, Cardizem.
I had a little trouble finding more about this one, honestly.
I don't know. Apparently you can lose your sense of smell. It's not just from plagues that bother the entire planet. I'm glad that I can still smell because I do know this. The vast majority of what you taste is actually what you smell. Mm-hmm. You can only taste 5 different things, but you have about 10,000 different unique smells that you can differentiate. And so if I lost that, that would be
quite terrible.
That'd be very sad. That'd be very sad. All right. Well, you guys just made my fun silliness a lot more serious, and I feel bad making jokes. So we'll just end it there, folks. If you are taking medication and you have an adverse drug reaction, please talk to a provider. These folks are here to help you be healthy, and we can't do that without information. So talk to your care providers. Anything that we mentioned, anything you want to check out on our website, go there, askjoedimatteo.com, askjoedimatteo.com. We sell all kinds of different fantastic supplements, natural health solutions, all there on the website. That's also where you can find past episodes of this show. You can find episodes of the show that started all this, the Ask Joe DiMatteo Show, or you can sign up for our email newsletter to know when everything goes on sale. If you have a question, we want to hear about it. Questions at askjoedimatteo.com is an email address. Just shoot it to us there, and we will get it on one of the shows. Any show notes or articles that we may have referenced will be available down below in the show notes section. And if you learned something, or you happen to hear about a side effect that maybe somebody you know or love is experiencing, send this episode to them. It helps us out, and it'll help out the person that you love. send them the episode. All right. Big thanks, as always, to Josiah Schweinberg. I don't know, man. Maybe I don't want to thank you today.
Is it too much? The past few episodes have been real quiet.
You have. So we'll see what stays in the episode. Maybe this is all we see you this
Keep
episode.
bringing it, Josiah.
All right. Thanks. I appreciate it.
Michael Deppish, our editor. Joyce Gibb, the nurse practitioner who handles private consultations. Big thanks to Diane Silverman, who manages our product. Terry, who does scheduling. Cecilia, who does distribution. That's Dante DiMatteo. That's Joey DiMatteo. I'm Tyler Andrews. Thanks so much. We'll see you guys next week.